knowing when to treat.
Use a certain amount of cylinder. So you may have a patient where the overall spherical equivalent might appear nearly the same, but the cylinder might be higher, where measured indicates the topography measured one and the refraction is your subjective refraction. For topography guided treatments, we tend to go towards more of the topography guided refraction, but we have to keep in mind that the overall spherical equivalent should not be changed beyond what the patient is accepting subjectively, especially if the patient has a good BCVA with whatever the subjective acceptance is. So the first and foremost step is to set the powers at 0 before you decide whatever you're going to correct. Set the power at 0 and look at the zero ablation profile. So when you're looking at the zero ablation profile, you can see that here the area where you are getting the maximum ablation is centered over the area which is maximally elevated on the anterior sagittal curvature, and the area above this is flat. So you have this arc-like mid-peripheral ablation which is going to give you an ablation over the mid-periphery and thereby steepen this cornea and flatten this cornea, giving rise to a more anteriorly normalized surface. So this correlating this zero powered map is most important, and only if this is matching well with your topography should you go ahead with the treatment. Next, the idea, once you have trying to do a topography, you can try and debulk the cylinder. Now, while debulking the cylinder, the magnitude can be taken from the topography. You are trying to reduce the magnitude, and even though in some cases it might actually be higher than what the patient is accepting subjectively. We are going more and more towards the topography refraction, especially when it comes to these keratoconic patients, and you might add a cylindrical power which might actually be higher than what the patient is accepting, but lower than what the topography says is the cylinder. Now, in some cases, you may have good correlation where it becomes quite easy to decide where the subjective cylinder and the topographic axis are very well matched, as in this case, and then it's a no-brainer with regards to what axis you're going to choose. But when it is quite different, as in the subsequent case, as you can see here, it's 100 and 165, so widely apart, we tend to shift towards the topographic cylinder. But before you go in with the whatever the machine is suggesting, have a look at the anterior float and look at the axis of the steep axis of the cylinder on the anterior float. As you can see here, if you connect the steepest point with the central point and draw a line, it is going towards the 160 mark as opposed to the 100 mark which your subjectively which the patient is accepting. So while looking at the anterior float is one of the best guides to see along the axis where you are correcting, and as long as it's closer, you have an additional validation to say that you're treating along the 165 axis, and that's what is happening in this patient. How much do you correct the sphere? So as long as you are keeping your ablation depth between 50 to 60 microns is where you're doing. You can also bring down the optic zone size from your standard 6 or 6.5 to 5.5 millimeter, which also reduces your amount of ablation. And you can keep adjusting the cylinder till you reach somewhere between 50 to 60 microns. An additional thing you can do is also add a small amount of hyperopia, which many of your patients, if you carefully refract, will accept. And this patient, even on subjective refraction, is accepting a small amount of hyperopia. You would do well to add that hyperopia here, because cross-linking itself is going to add a little bit more flattening and will have a certain subtle shift towards it. So if you do that +1, from your 56 micron, your central maximum ablation has already come down to 50 micron as more ablation is being added to the mid periphery, and your central ablation actually starts coming down. So this is an additional small tip that you can use to slightly reduce your amount of ablation depth in the center. So just running through a quick examples which before I close. This is the example which we were working on. I was showing you the planning. The pre-op vision uncorrected is 636, BCVA of 6.9. The post-operatively patient has a 6.6 parts vision, and with just about 0.5 diopter cylinder improves to 6.6. This is an example of a centered cone where you can see on the posterior float the point is very much within the central 3 millimeter zones, the most elevated areas. And these patients do extremely well with good 6.6 vision. But even in patients with decentered cone, as you can see here, where majority of the cone is outside the 3 millimeter zone, even many of these patients do well. These are again patients with good pachymetry where you are able to reduce it, debulk it, and you have a much more symmetric cornea, and the visual acuity also improves. Yes, you do have a residual cylinder on your astigmatism. The patients markedly improve in their uncorrected and best corrected visual acuity. This is again some examples just showing the curvature, much greater symmetry once the procedure is done. In these very central nipple cones, in the postoperative, just if you look at the axial curvature without looking at the posterior cornea, you won't even know that they had keratoconus to begin with. This is how well, if we do a careful step-by-step planning, how well topo-guided PRK can work in these patients. Quick point about whether manual epitheliectomy versus PTK. One of the things is the challenges which continue to remain is we are not able to have lasers which really map the epithelial thickness which varies from center to periphery. And that is the problem in keratoconus, where epithelium can to some extent mask the cone. So if you have a topography where you've taken with the epithelium on but manually remove the epithelium which is variable from center to periphery, and you have a slightly altered topography on which you're treating the cornea, for that possibly a PTK might be better, where you're removing a uniform 50 micron or 40 microns over the entire treatment zone, and then you have a topography which kind of mimics what you had measured before your epithelium was removed, and that is possibly what works really well in these cases. We still have a lot of unanswered questions. How much ectasia? What should be the maximum attempted correction or ablation? And then what is the dosage of CXL to be administered? Especially with the advent of customized cross-linking, how do you combine? What nomograms do we follow? It's still an evolving science, but exciting days for these mild to moderate keratoconus, where a number of them can be rehabilitated extremely well, only in early keratoconus, just to reiterate. Thank you so much for your kind attention.
Any questions?
Any
for
quick
Shreyas?
questions? For
I think maybe one question and one comment. In patients who are relatively young, below 18 years, though it's quite okay to do PRK along with the cross-linking, do you think it's a good idea to avoid doing it because they might require a repeat procedure later on, or do you think you have no age cutoff?
So I've not treated preteens, but teenagers, I mean like between 14 to 18, we have been treating, and for most of these patients, I now have a 5-year follow-up. Yes, there are patients, very, very rarely where reported in literature, pediatric cases who've been treated early in crosslink have required a repeat crosslinking procedure. But looking at our data, I'm not sure in LVP as well, sir, how many patients have actually required a repeat cross-linking, which is not very, very, very common. These patients, however, are regularly followed. We have a post-operative scan at 2 or 3 months done, which is the baseline scan, and every time it is documented and we follow them up. And if necessary, yes, a repeat cross-linking will have to be done. I'm not sure if the topo-guided PRK itself may increase the risk of progression.
Do you do this in a patient who is having 6/6 vision?
So
Best corrected.
Yes, 6/6 best corrected. Now, again, a lot of these patients may read 6/6 on your Snellen's chart. Obviously, if it's uncorrected, I wouldn't do anything. They are probably very well adapted to their cone, and I would just go ahead and just do a cross-linking. But best corrected 6/6, a number of these patients who are 6/6 best corrected, as long as it's a good planning and a good treatment which has been done following the basic principles, their overall quality of vision does go up. Their higher order aberration profile, if you do believe in it, also does improve, and it does have an impact in their overall quality of vision. Definitely, their uncorrected visual acuity does improve. Even if their BCVA obviously will continue to remain only 6/6 and is not going to go better, but their uncorrected visual acuity and overall quality of vision does improve. Again, that debate remains even for cross-linking itself. There are a small percentage of patients who do develop haze after cross-linking. So would you cross-link a patient who has 6/6 vision? As of today, I don't think we are using vision as a criteria for cross-linking. Even when we are talking about progression and age, those are the more important criteria than vision itself. It's not uncommon to see patients